We are now set to begin our next session. We are good? Everybody's okay? Everybody is full? Hyperglycemic? Studio? Yeah, very enough. So in our next session, I think from our previous session, we have had a number of abstracts being presented. And I'm sure that so many of you have questions on the researches that have just been presented here. So on our next session, the abstract presenters will come forth together with Chege, and maybe you will forward your questions to them for a short while. They answer, then we carry on. Is that okay? That is in order, right? Sawa. So abstract presenters, the stage is yours.
Hello. We're going to have a brief session for questions for the abstracts that have been presented. So we'll have Cedric, Benjamin, and Faith, and also Victor will come and help me ask some of the questions. So we want this session to be 15 minutes tops. So this session is open for you guys to ask questions. To the people who presented the abstracts. You can ask them about their research, the work that they did. Yeah, so I'm waiting for Cedric. We want to take 20 minutes max. Okay, so thank you everybody. Thank you for keeping time. Thank you for coming back in time. I'll just give the panelists a minute each to introduce themselves and tell us what the abstracts they presented.
Hello, good morning once again. My name is Cedric Ambenje. Here, the presentation that I did was about reformed abortion laws in sub-Saharan Africa and the relation to the relationship to unsafe abortion.
Good morning again. My name is Benjamin Nyeriki, in my final year of medical school in Jkuat. My presentation was on effects of the shortage of diabetic medications at Mama Lucy Kibaki Hospital.
Good morning once more. My name is Faith Atieno. I'm in my final year as well. And my research was on perception of caregivers on asthma, perception of caregivers on stigma surrounding asthma, and as well as their perception on asthma, establishment of asthma peer groups. Thank you.
Yes, good morning everyone. My name is Victor Mukuni. I'm in 5th year MBCHB Jkuat, and I'll be moderating this panel together with Maina Chege.
Okay, thank you. I think I'll start off with one question, and then Victor will also ask a question, and then we'll open it up to everybody. I want to ask Cedric first, because your study looked at, if I'm reading it right, it's the unmet need for abortion law reforms and modern contraceptive uptake in Kenya, Nigeria, Ghana, and Ethiopia, a systematic review, and you did it with people from across the continent. I just want you to take a minute and tell us the experience of that and how you got to meet these people, because I'm sure people are curious. How do you meet somebody who is in Nigeria and somebody from Ethiopia, and you end up doing work with them? And then after that, Benjamin and Faith could probably answer, because your studies were done under HAPI, how that entire experience was.
Thank you, Chege, for that question. So in 2019, late 2019, early 2020, I was the publicity officer of Federation of African Medical Students Association, that is FAMSA. And in the process of organizing the event, the GA happened in General Assembly and Scientific Conference, happened in February 2020. And there were delegates from across the continent, people from West Africa, people from Eastern, South, Central, and even Southern Africa that came. And I bumped into these guys from the conference, and that's how the idea came about, because they were also interested in matters sexual and reproductive health and rights. So when we when I established a relationship with them, we formed a WhatsApp group, and there we went. We brainstormed on various topics that we would do across the board, and we used to do Zoom meetings and long phone calls, and that's how we kept doing the work, assigning everybody the section they were supposed to do. Like Daniel Otobo and I were the ones who were doing the, harmonizing the manuscript. So we would make calls across, and that's how we did it.
Thank you. There's no mentioning of HAPI in Jkuat without mentioning Dr. Mburugu. So, Dr. Mburugu, thank you so much. Two, my mentors, Dr. Penina and Dr. Maureen, who are seated on the other side. When I was in my 4th year, they were in 6th year, so we were rotating together, and they kept mentioning about HAPI. They kept mentioning about HAPI, and I was curious, what is HAPI? And it was around that time that I also developed my interest in research. So getting to 5th year, I got an opportunity to apply for the HAPI program finally. And HAPI is curated in such a way that you do it as MBCHB students, nursing students, and pharmacy students, which I think it is a great idea, because if you look at the current kind of research that is done, it's normally multidisciplinary. You realize that, or you think that you know so much up until you interact with someone else from a different field, looking at the same idea from different perspectives. So that is what HAPI has done for us. So we picked a topic that was both on clinical work and pharmacy. We had a pharmacist, a pharmacy student in our group. We had a pharmacist called pharmacist. We had a nurse who has done a PhD in nursing. We had a pediatrician as our supervisor, and we had MBCHB students in the same panel. So you realize the work that we've done at the end of the day is not what would have been done by people from a single discipline per se. So thank you.
Okay, good afternoon once more. So in regards to this journey, the HAPI journey, one, I'd say that my interest in research started way back when we were introduced to research. That was in 3rd year. We progressed to 4th year, where we were taught how to develop our research proposals. And then later in 5th year, we did complete research. And I think this captivated me more, and I wanted to do more of research work. And then now through HAPI, thank you to Dr. Mburugu, I applied for HAPI, and I got a chance to do research. And through this platform, I think, and also with the help of our mentors, initially we were told that how do you choose a research topic to work on, and how do you implement this, and how do you work with your mentor? So in as much as I had an interest in research, and also I had a research also in respiratory health, I think through HAPI, and also with Dr. Simba, who is also a pediatric respiratory doctor, through him I was able to establish a title for the research for this HAPI program, and through it we actualized the abstract that I presented today. I think for the journey that we've had through HAPI, it has taught us a lot as young researchers, and initially we thought that we knew much. After being taught in 3rd year, in 4th year, we thought that we knew much about research. But I think through their guidance, you get to know that there's more to be done in research, and there's more to be worked on, and more to be implemented. And I think through that, I actually actualized this dream in working as a researcher. Thank you. I don't know if I answered the question.
Okay. Asante sana for that, And as we're looking at the theme of today's conference is enriching medicine through undergraduate research. And for those who are asking what HAPI is Health Educational Partnership Initiative. It's an initiative to enrich undergraduate research, to give a pipeline for young researchers who are in their undergraduate school. And it's really encouraging that we are getting great researchers and great people being trained and mentored into research. And just a follow-up to Faith Atieno, it's a coincidence that I am doing a follow-up study on asthma, on the same topic that Faith Atieno is doing. So we are doing a follow-up study to that. And just to ask, how do you feel your research has impacted the provision of care at the respiratory pediatric clinic?
Okay, thank you for the question, and congratulations, by the way, for doing the HAPI program. I think it's a good platform for your research as a young researcher. And then as in regards to my research and the impact it has had, we just concluded the research not too long ago. And I think we are in the phase that we are now disseminating this research and hoping that it will bring out the desired impact. And I think we have not disseminated it yet, but I think through our research we are going to improve perception of the general population regarding asthma, and also through the caregivers, through their education, we are going to improve the treatment outcome for this patient, and we are going to reduce the morbidity and mortality in regards to asthma. Okay.
Yes, asante sana for that. And just to give an appreciation, it's through the establishment of the peer groups that they established that we're able to do now our study. And asante sana. And back to Michege.
Yeah, so thank you so much to our panelists. This is a point where we open the floor to people who have questions to the people who presented abstracts today, so that you can put them. You can put your questions to them. So if you have any question to regarding the abstracts that were presented, either Cedric's, Benjamin's, or Faith's,
feel free to ask a question. Yeah, thank you.
Hi, my question is, in the research that you all conducted, all the people involved were basically medical students and medical personnel. Those are the only people that are involved in your research.
You've gotten the question? Are you asking why there are just medical students involved? She's asking if the research you all did, were they only done by medical students, or were there interprofessional engagement?
Thank you for that question. So, for me, the people I collaborated with were medical students, and it is because of the background that we had. We were all medical students. We met at a medical students conference, and we proceeded with research. Otherwise, had we had people from other professions that were willing to collaborate with us, we would have had them on board.
Thank you for that question. I've done 2 research projects so far, one as an individual, the other one under the HAPI program. So the HAPI program focuses on medical students, pharmacy students, and nursing students. On the other hand, we have research clubs that we have so far. And like I said to the previous question, research is moving to a phase where it is multidisciplinary. When I was doing my research, there are things that I wanted to do, but I couldn't do. I had to go to YouTube to learn some of them. things like data analysis. We don't have so much time in school to study data analysis. So I had to go do my own classes in YouTube. But if I had a statistician, someone who's doing biostatistics, and they have been exposed to much of this, it would have been way easier. So under the research clubs that we have, we have always been pushing towards having people from different backgrounds, academic backgrounds, such that when you do a project under that research club, then we have different experiences. But so far, the ones that I've done, it has been the people in the medical field.
I think Benjamin answers the question for me. But by medical students, do you mean the MBCHB students, or did you mean did you have another meaning to it? So under HAPI, my research was done under HAPI. We were 2 MBCHB students. We had 2 nursing students and 1 pharmacy student. So you find that under HAPI, the research is quite multidisciplinary. Thank you.
Okay, asante sana. Any other question?
Hi, my name is Cynthia from the University of Nairobi. My question goes to the research on diabetes, the medicine. Okay, we understand the why now part of it, but now the impact, yeah? So after the research, what have you done? Like, are the drugs now available, or are you still in the process of finalizing your research?
Maybe if we want to let the next person.
Okay, Benjamin, hi.
Hi.
In your methodology, I think you said you calculated the sample size and then you corrected it. Could you just explain why and how? Yeah.
Okay, thank you for those 2 questions. So the first question was on what we've done so far. So this is actually the first time we are disseminating our data. Our findings. We just finished the research project recently, so we've not done so much as getting our findings out there. But going forward, we want to share these findings that we found so that it helps the patient ultimately. We realized that diabetes is a long-term disease that needs long-term management. And as we are moving forward, the cost of managing this disease, unless there are drugs in the facilities, then the diabetic patients are forced to buy. So if someone is earning as low as 15,000 shillings per month, and we understand that we have families, we have so many, and we understand the current situation of the economy, this will be competing, and it's more likely that this person will forfeit getting the medications than missing to get food on the table. So should we get our results out there, then we hope that the government finds ways in which we can leverage on the available resources to get more medications, because maybe they're supplying the same amount of drugs that was used to be, they used to supply long time ago. Yet each and every day there are new diabetic patients who are diagnosed. So we also want we hope that the government will take this up and also work together with organizations like PSK, so that they can regulate the cost that the drugs retail in the private chemists, so that they caution the diabetic patients from being exploited financially. I hope that has answered the question so far. So on the other question on methodology, we used Fisher 1998 formula to calculate the sample size and got 46. Given that we used a prevalence of 3.1% according to the Ministry of Health in 2021. So the sample size that the target population that we are using was less than 10,000 individuals. And you realize that, from Mama Lucy Kibaki Hospital, their target per month is around 260 patients, including adults and pediatric population per month. So in the study period of 3 months that we considered in 2021, that would amount to around 840 patients. So we had to correct that so that we got 44, using the correction formula to get 44 patients.
Thank you so much. I think we'll have to stop at that because of time. Thank you so much, Faith, Benjamin, and Cedric, for your time and for your presentation. Asanteni sana.
Thank you so much, the panelists. I know that some of you have more questions. Don't worry, we'll answer all those questions. So just forward the questions to me, then I'll get you an audience with the researchers. So our next presentation antibiotic microbial resistance and the future of antibiotics. Our presenter will be Professor Gunturu Revathi. There's so much to say about Professor. She's a microbiologist, consultant microbiologist. She hails from Aga Khan University. She's an hospital, an associate professor at the facility. She has published 60 papers in reviewed journals, and she has interest in researches on salmonellosis, antimicrobial resistance, surveillance, and mechanisms of resistance. So please, let's put our hands together for Prof. and let us all listen in. Karibu, Karibu. Thank you so much.
Presentation connected. Thank you very much. That was a very generous introduction. I hope to live up to the expectations. It's such a pleasure. Thank you, organizers, for inviting me here to share a few of my experiences, my thoughts, some ideas with this brilliant gathering. I'm very happy to be here with you, young doctors, young medicos, our hope for future. Thank you very much, all of you. What I want to present, I was asked actually by Dr. E to talk about climate change and antimicrobial resistance. I must confess, I'm not an expert on climate change. What I know is what we know generally from the media, what is being published. So I'm as knowledgeable as you are. However, in bacteriology and antimicrobial resistance, I have some experience being older than you, not because of anything else, not because I'm more intelligent, same intelligence, but I was born earlier. So I have some experience, as simple as that, I can share with you. So that is what I'm going to focus on. Because you are all medicos, it's very, very relevant, and I apologize to the organizer for taking that liberty. I'm going to talk about a burning topic for all medicos: nurse, pharmacist, clinician, any clinician, surgeon, ops gynae, pediatrician, physician, it could be anybody, and also the laboratory, the diagnostic, the one who is doing radiology, diagnosis, maybe X-ray, CT, whatever, it's a diagnostic, and laboratory is also diagnostic. For them, the burning topic is antimicrobial stewardship. Stewardship is to control, rationalize the use of antibiotics, and by doing that, we can control and mitigate. We can't eliminate, but we can control antimicrobial resistance. And antimicrobial resistance is the greatest pandemic. Even before COVID came, it has been there, it will continue to be there, and it is resulting into massive economic loss, millions of deaths, and you will see all those frightful publications. So quickly, now the timekeeper can stop me anytime. The presentation is made in such a way for this kind of conferences. If you stop anywhere, it doesn't matter. Each slide has a different idea, different theme. So if you stop after 10 slides, it doesn't matter. 15 slides, doesn't matter. So feel free to stop me anytime. I simply stop. Okay, we agree. So that is my credentials. There was a very generous introduction. I am a clinical microbiologist by profession. This one is blocking my view. I want to look at the audience to keep connected with them. I have no conflicts, that is, I am not taking any payments for doing this lecture. These are all the resources for the presentation, so we don't go into each one of them. So this is to acknowledge, these are the sources. I am not the author. I am not the poet who composed the poem. This is Aga Khan University Hospital, the Temple of Learning. All universities like this one, Temple of Learning. Quickly, some shots of the hospital. All of you know, this is our retired president, His Excellency, inaugurating the University Center. It was such a pleasure. He did a beautiful talk about the importance of education. ICU in Aga Khan, single rooms for infection prevention and control. That is a JCIA requirement, the accreditation, international accreditation requirement. Laboratory, the core laboratory chemistry, that's molecular and bacteriology section with my microbiologists. They are my gods and goddesses. This is another god, bacteriologist with an automated system. This is the teaching lab. Again, a temple of teaching and learning. This is the teaching labs where we were doing a training program. Teaching labs. AMR is a complex problem. Yeah, how complex? That knot is showing, right? Vicious cycle. The more we use antibiotics, the more resistance we produce. And we have to use antibiotic to save life. There's no way I can tell a doctor, don't use antibiotic. You have to use. As you are using, you increase resistance. So it is a vicious cycle. You have to break it somewhere. If you don't break, you have to control some of the links. We can't break it because if somebody needs antibiotic, you have to give. There is no ethical permission not to give antibiotic. If your patient is in ICU, he's seriously sick, all of you know, you are medicos. You have to give antibiotic. I can't preach that don't give antibiotic. We want to control AMR. That is not going to gel. You don't have legal sanction, you don't have ethical sanction to do that. So, it is a vicious cycle. One health. This is the slogan WHO is giving us. Animal health, environment, human, all these bacteria, parasites, everything is single cycle. As it was described in the Old Testament. You have references for that in the Old Testament. Now what is this? This is about massive use of antimicrobials in animal husbandry, agriculture, in animals, chicks raising everywhere. Even in honeybees, when they raise honeybees, they use antibiotics. This is website where antibiotics are used in kilos. We buy ciprofloxacin 400 milligram capsular tablet, 200 milligrams or 150 or 250 milligrams. But the vets buy them 10 kilos, 20 kilos, 100 kilos. This is Alibaba.com website. You buy it for some $15, 100 kilos or 20 kilos. So when they are using antibiotics like that, and we sit here and we say that don't use antibiotics, is it going to work? So think about it. Honeybees. Antibiotics are used there also. Now this is quickly. We won't go into all the details. These are the tests. Those are the diseases, you know, meningitis, pneumonia, like that. And that side is what is called priority pathogens. You all should know this by heart. Okay? Priority pathogens. Critical priority, high priority, and some medium priority. That is the classification. This is very, very important to understand the concept of AMR. These are the conditions where we use antibiotics without any rationale, because patient is seriously sick, you don't know what is the pathogen, but you prescribe an antibiotic. Lot of them are viral infections, but patient gets an antibiotic because you don't have diagnostics. That's what this slide tells you. What is the condition of labs in low middle income countries? Low income countries, no labs. Lancet Commission, the paper is out. Lancet Commission is telling us that 50% of the world population, this is including Australia, Canada, the rich countries, have no access to lab tests. NHS England, no lab test. You can't even get a hemoglobin. If you are an antenatal patient, you go to NHS clinic, not even hemoglobin is done because no money. Doctors are very bad at interpreting the results. This is another problem. You see, these are independent themes. If you ask me to stop the presentation, I can stop here. So different themes. So this is a study, US, this is in US, rich country. They have everything. They are the gurus for us, right? So they say that the doctors don't read the tests. They don't get the results. When they get the results, they don't know how to understand. This is also for, they don't know how to order tests. If I have patient with moderate pneumonia, which test should I order? I'm not sure. And then the menu says that I have biofire, I have this molecular, this whatever, all the tests, I don't know which test to order. So it's not good for diagnostics. It's bad news, right? Okay, we have seen laboratory improvements recently because private sector realized it's a money making. Lab is a money making. So everybody has opened a lab. Everybody has got a certificate of accreditation. But inside, what is happening? I won't tell you. Quite a challenge. What is this challenge? How these doctors are using the tests, they are ordering the tests, which I have already said, and doctors are the ones use the results. They also make the guidelines, they also make therapeutic decisions. So doctors are at the core of this business. Doctors, I mean, could be a nurse, could be a pharmacist, anybody, like I said, multidisciplinary. So this is the definition of antimicrobial stewardship. You find a lot of definitions. You Google, like the doctor was saying here, go to YouTube, you'll find a lot of definitions. You can choose the one you want, but this more or less captures is the process of making guidelines, rationalizing the prescriptions. That is antimicrobial stewardship. For any stewardship, you need guidelines. You have all these international guidelines. They are free, they are online, on YouTube. Anybody can access them. But how do you apply them to your environment? It's very easy to get them online, free resources. How do you apply them to your clinic, your patient, your ward? That is the challenge. All these are guidelines. We have all these guidelines. And they are publications. These are local publications from Aga Khan, our own antibiogram. And this is how the data looks. For you to do antimicrobial stewardship or diagnostic stewardship, which is another song these days, you need data like this. How many labs can generate data like this? Now, Aga Khan laboratory generates data like this because it's a $1 million investment in CAP accreditation, JCI accreditation, IT system and all that. You can generate this data. It's not very easy. Even then, this is a lot of manual work. It wasn't automatic. You have to do a lot of sweating on the data to create this. So this process is very difficult. ICU, OPD, ward, like that, you divide the data. You have, this is called a layered antibiogram. You divide it according to the location of the patient. And now you have this trends analysis of the urine cultures from the outpatient. OP is for outpatient, and you have 2012 to 16, and you have the bars which are different colors, and they are different agents, starting with I think amoxicillin clavulanate, third generation cephalosporin, Cipro, like that, all the antibiotics. And you have the trends. Is the resistance mounting, resistance is staying, like that. Now, is this really true? Why? Because these tests are all requested by doctors anyhowly. It's not a study. It's not epidemiology. The doctor requests. One doctor requests all blood cultures. Another one is only requesting urine culture. Another one doesn't like sputum culture. So they do anyhowly. They request all those cultures come, and we grow the bugs, we report them, and then you generate those graphs. So is it really surveillance data? Can you make guidelines depending on that? I want all of you to understand that point. Laboratory data, which is just generated from the laboratory books, cannot be extrapolated to surveillance data. Okay? Another point there is these patients are already on antibiotics. A doctor is requesting a culture request only when the patient has failed treatment. UTI you have already treated empirically with ciproflox. Patient is still running fever. I was discussing with our young doctors here, and now you send a culture. So all those are biased samples. So please get this straight. Doctors are clamoring, we want antibiogram, hospital antibiogram. Does it help you really to manage, to empirically prescribe? Is it synonymous with surveillance data? The answer is no. And all of you know now what is the reason, right? This is integrated model of stewardship. ASP is antimicrobial stewardship. DSP is diagnostic stewardship. What is this diagnostic stewardship? This is the right test for the right patient at the right time, and the result is timely. That is, you do a blood culture, you have some result while the patient is alive. Usually the blood culture result goes, the patient is already reached heaven, and now the doctor is getting the result. What does he do with it? Really, the relatives cry because they have to pay for it, and patient is already in the mortuary. So right test, right patient at the right time, leading to a right management and improving the patient outcome. So that is diagnostic stewardship, and at the joining both is infection prevention stewardship. If there is a multi-resistant bug, there is a virus, or there is a bacteria, there is a salmonella, there is an enteric pathogen, whatever it is, a respiratory pathogen, you prevent it from going to the other patient, or you prevent it from going to the neighbor, within the family, in the community. So, antimicrobial stewardship, diagnostic stewardship, infection prevention stewardship, it's an integrated model. They feed on each other, they feed into each other, they are interdependent. If you separate them, you fail. Thank you. COVID actually highlighted all these problems of diagnostic. We learned that if you don't have specific diagnosis, you go nowhere. For controlling COVID, overnight lab capacity had to be built. We used to say that PCR is not accessible, it is impossible for low income countries, but we started running PCRs under the tree, in the vans, in the all those, what were they called, mobile laboratories. Anywhere you are running PCR. Earlier we were told, no, you need 3 rooms. There should be amplification room, there should be sample processing room, all those should be separate. You can't start the PCR in your lab. You will not be allowed. But we started doing it even under the tree. So overnight, philosophies will change. And the pandemic preparedness taught us that diagnostics is very, very important. If we have to control AMR, we have to have specific diagnostics. I think I skip all this because I have only 3 minutes. There are a lot of online resources for this knowledge. This is a free course online. You all know. AMR is antibacterial, antiviral, antiparasitic, antifungal, right? Antifungal resistance. Candida auris, resistant fungus, has played havoc all over the globe. How does the lab help? Laboratory diagnostics, how does the lab help? Pre-analytic, analytic, post-analytic, everywhere the laboratory can dictate the stewardship by doing some things, by not doing some things. Sample collection, lab can teach. Choosing the test, sensitivity, specificity, which is the pre-test probability, all those lab can teach. Ordering urine cultures, when order should be done, when it should not be done. You can control AMR, control antibiotic use by controlling the culture requests. Blood culture, contamination rate, laboratory perspective, sample collection, site preparation, all these are standard operating procedures for the laboratory. Urine culture, some examples, I think I skip all this. Reflex urine culture, that is when there is pyuria on microscopy, you go ahead and do the culture and then release the results. If there is no pyuria, don't do the culture. If you give a sensitivity, the doctor is going to prescribe antibiotic. That is the philosophy. More analytic interventions, we skip all this. Rapid testing, rapid diagnostics. Lot of new technologies. These are all the new technologies which will impact on diagnostic stewardship directly. This is syndromic testing, BioFire. This is a machine, expensive though. You have 4 syndromes. Each syndrome has 20 pathogens, but you get a result on all of them at a go in 2 hours. Fantastic for diagnostics. Waved tests, rapid tests, so many are there. These are point of care molecular tests. All these are available, but are they available in Africa? The answer is actually no. This is again studies. You can skip all this. Selective reporting of antibiotics is what I want to tell you. Is you have antibiotic panel, you have tested 8 antibiotics, but report only 4 of them. Don't release everything to the doctor. Only the narrow spectrum 4 antibiotics you release, and for that you have a standard operating procedure in the CLSI manual. All medicos should be familiar with this manual. I think I have done. These are some culture plates which, if the tech knows how to read, he will do the right thing. If he doesn't know, it's a training element. He will release sensitivity on this protease. We will promote antibiotic resistance. Now, I will just take a few seconds to show these plates. This is microbiology lab promoting AMR. Please be aware. Can the microbiology lab promote AMR? Huh? What is this professor telling? She's too old. She's now getting Alzheimer's. No. No. This is protease. It should not be reported. But it's a training element. The techs don't know. There are no pathologists to tell them to oversee. So he will release a susceptibility. Doctor will prescribe an antibiotic. You are promoting AMR. This is a mixed culture. If you put 2 types of colonies into the machine, you have a lot of machines nowadays. Labs are buying these machines. You get an MRSA. There is a Staph aureus. There is also a Staph epidermidis. If you put both colonies into the machine, it will give you a result of MRSA. And the tech doesn't know, there is no pathologist. It's a training element. This is the mixed culture. You see the pink colonies is normal flora. The golden colony is Staph aureus. You have to pick them, purify them, which is a technique, needs specific training. This is the same, golden and pink colonies. This is mixed urine culture. I can tell you with a guarantee, in this country, lot of county referral hospitals are now doing donor-funded antibiotic sensitivity testing. Donors have given some material, some machines, so they are all doing antibiotic sensitivity testing. They don't know that this plate should not be reported. It should be discarded. But it is a training element. The tech will pick some colonies, put them into the machine, release an antibiotic sensitivity test, which is promoting AMR. This is Acinetobacter. It's a spot diagnosis. Either you know it or you don't know it. If you don't know it, you will release some antibiotic sensitivity. This is nocardia, the gram-positive filaments. The patient needs only Septrin, just gram smia, only 50 shillings, gram smia. If you know, 10 minutes, this is nocardia species. And treat the patient with Septrin, cheap antibiotic. Patient will be fine. Within 48 hours, he'll recover. It is fantastic. If the lab can't do it, most of the labs can't do it. It's a training element. The patient will be receiving amikacin, meropenem, fluconazole, metronidazole, one after the other, until he dies. Thank you very much. I don't want to leave on the note of death. These are all the international agencies which are funding AMR, AMS, DMS, DS, DP, whatever. This is the summary. I think we can skip that summary. There are a lot of herbalists all over the globe. This is the herbalist in Canadian laboratory in US. All US universities have now opened what are called institutes of alternative medicine. They are basically herbalists. What is the solution for all this? Is it only problem? Is there no solution? Standard medical education. sincere education. Truth, knowing the truth. Education is knowing the truth and practicing the truth, and that is important, and this is where it is happening. Young medicos, I'm so happy to be sharing all this with you. Thank you very much. It's in your hands, and this is hand hygiene at the core of antimicrobial resistance. Thank you. That is my institution. Thank you very much. Thank you for your patience. I've taken longer. Sorry.
Thank you so much, Professor. From Professor's presentations, we've learned that you are the source of antimicrobial resistance. True. Medical students, medics, loading medication, loading antibiotics to the patient is not treating them. You're actually making it worse. So thank you so much, Professor. And thank you for telling us that we can control antimicrobial resistance. We can do it, only if we are educated well enough. So I think I'll allow two questions to Professor. Then we can give to Professor and get on to the next session. This is an interesting topic. We must have questions. Very interesting. Anybody with a question? Thank you. Thank you. The guy with the good blazer.
Come on. Okay. My question is to Professor. What do you think is the intervention of the government and the healthcare systems in managing AMR? Because these healthcare systems is where we go to get them, we as patients and as citizens of Kenya.
This is a political question. Do you think I'm competent to answer this? I'm a poor professor. Yes, we all have responsibility, all universities, which are supposed to be free institutions. Yes? Universities are independent, autonomous institutions. So it's our responsibility to the extent that the education, the knowledge and the truth, seeking truth is at the core business of the universities. To that extent, yes, we must do what we must do. When it comes to government, continuously we hear that there are no resources. Now, it is 50-50. There are no resources, yes, true, but there are plenty of resources which are being spent. So, we wanted all these things to come through the universal health coverage. It's a big topic again. So, universal health coverage should dictate that there should be IPC, there should be diagnostics. However, when the donors come, even this is donor funded. Unfortunately, everything is donor driven. That when the donor come, the donors say that we will fund the medicines. So they will fund the antibiotics. You can prescribe. They won't fund the diagnostics. When they fund the diagnostics, they will only fund the programs which they are interested. So in silos, they funded malaria for so many years. They funded HIV for so many years. And then they funded, I think, COVID, they are funding now. It's forgotten, like TB doesn't exist anymore. Nobody is talking about TB. Nobody is talking about malaria. Nobody talks about HIV. All the patients are cured. These diseases have disappeared. We only have COVID now. So they are funding COVID. So it goes like that. But the intellectuals, the civil society, the respected citizens put a pressure on the government to fund diagnostics through universal health coverage. So far it hasn't happened. Hopefully it should happen because there is a list of essential diagnostics which has been released by WHO. Now that essential diagnostics is married to a list of essential medications. So in that list, everywhere it says for every medication, diagnostic should be there. Hematology, chemistry, bacteriology, culture. For all antibiotic prescriptions, it says Thank you. You were listening very carefully. I'm so happy. So most of the time when we are lecturing, we don't know we are lecturing to the roof or to the floor, to the windows. Thank you so much. It was highly contextual. Proteus is not always a contaminant. Proteus is a fecal organism. Every animal gut has Proteus. So if you culture stool, you will grow Proteus. Now, the plate which I was showing was from a wound swab. Okay? Wound, you take a swab and you inoculate a plate. And on BA, if Proteus is swarming, you cannot even God cannot do it. With all respect to God, He also says, okay, let's not attempt this. Let me not do this. So it's very difficult. Technically, it's very difficult. So what you should, microbiologist should do is ask the doctor to collect another sample. When he collects another sample, remove the superficial debris, the necrotic exudate from the wound, go deeper and get a swab and do a culture. So your advice to the doctor is to collect another sample. But Proteus can grow in pure culture from urine. If it is outpatient, you don't do susceptibility because healthy people cannot have Proteus UTI. This is again knowledge. Either I know it or I don't know it. However, if this patient, the same plate, the patient is in ICU, he is with a catheter, pure Proteus is growing, I should call the ICU and ask what is the condition. This patient had a transplant, is a post-surgical, what is the background? Depending on the clinical background, this Proteus becomes a significant isolate. Then you must report the susceptibility. Proteus is a nosocomial UTI pathogen. It can cause pathogen. Similarly, enterococci. They are normal flora, they are contaminants, they should not be reported usually, but in a hospitalized patient with a serious background, you have to report it. So it's an element of clinical training. That's what I'm trying to tell you. So if that clinical background is not there, if a tech is independently culturing organisms, picking them, he has some internal QC, he's releasing antibiotic sensitivity reports, the doctors again due to lack of knowledge are prescribing, microbiology lab is promoting AMR, unfortunately. I'm seeing it every day. It's very painful. Thank you for that question.
It's an interesting topic, just as I said earlier. I think we just take one last question from Cedric. Then I'm sure so many of you have questions. Just write them down. We'll forward it to Prof. Then Prof will respond.
Hi, Prof. How are you?
I think I'm good. I've survived 4 COVID waves at this age. But I have become asthmatic. I keep coughing, and then people think that I have fresh respiratory infection. The asthma which people were discussing, I'm the subject.
Hope it resolves. My question is, you talked about heavy antimicrobial use, especially for livestock such as poultry, aquaculture. And my question is there concern about emergence of new strains of microbes from overuse, or is it by accumulation of these antibiotics to the livestock that then we get to eat and then it interferes with our system?
Thank you so much. I refer to the slide which I showed you with an umbrella, One Health. There is another slide which WHO website is very fond of, that is soil, air, water is one cycle. Yeah? In creation, that is how God made it. The air, the soil, the water, they are all interconnected, right? Water sinks into the soil, water gets evaporated and becomes cloud, and again rains and goes into the same soil. So it's a cycle. So antibiotics, when they are used, they are consumed, the animals excrete them, and they are used in the farm, and then they wash into the soil. So antibiotics have now accumulated in all our rivers, in the seawater, in the lakes like Lake Nakuru, Lake Victoria, any lake. I believe Michigan Lake, they did a study. There are antibiotics, anti-diabetic drugs, anti-hypertensive drugs. And then the fish, when they drink this water, they are also exposed to all these drugs. And there is physiological changes in the sea animals. So it's happening. And because of that exposure, microbes are becoming more and more resistant. They are evolving as they are continuously challenged. Not just by antibiotics, all drugs which are going into water, all the chemicals, that is the pesticides, the antifungals, the those moths and those things, which the the farmer is using to spray. All those chemicals, they are terrible chemicals. They have an indirect pathway to stimulate resistance in E. coli. So even if somebody has not used antibiotic, he can acquire a resistant E. coli. So our meat has antibiotic resistant organisms, the eggs have resistant salmonella, the butter, the ghee, like I say that I am a vegetarian, I won't be exposed to all these things, but the vegetables, the fruits, everything is antibiotic. Nobody can escape it. So I think that is what you are driving at. Thank you so much.
Thank you, Professor, for responding to those questions. Don't worry, my people. You'll get the chance. Your questions will be answered. So you just write it down, forward it to me. I'll find a way at which you can get answers. So I think it's about time we appreciate Professor. We have something small for you, Professor, for having time for us, presenting for us about antimicrobial resistance. I think Maranga will give Professor the gift. And as Professor is receiving the gift, please, round of applause. And to our first years, I know today you've had some new terms, proteas, culture, usiogope, don't fear. These are things that you will read and you learn about ahead. So write it down, andika tu mahali. Then you go and read later. Ikishindikana niite, I will explain it to you. Thank you. Thank you so much. You want to stretch? You guys want to stretch? You can just stand up and stretch. Mmekaa sana. Nimeona mtu akilala huko nyuma. Please just stand up and stretch for 2 seconds, then we continue. Guys, you're not standing up to stretch. I think I'll help you. Everybody stand up. Can
Thank you, cause you keep on blessing me. Keep on blessing me. Keep on blessing me. Keep on blessing me.
Wanjau, the colleague of mine, please come and take us through the stretching part. Wanjau, please.
Keep on blessing me.
Please come for Wanjau.
Thank you, cause you keep on blessing me. And when I step in the place and I look like a star, say them put say I did do shaka fry. Anyways, them I see me, they want to reach jaga jaga. I'm moving, I'm just in my body. Do you like what you see?
I'm not Eldon's colleague. I'm from MKU, not from Jkuat. We don't want any. Okay. Hiyo ni story yetu na Eldon. So my name is Wanjao. I'm from Mount Kenya University, and honestly, I'm very overwhelmed by all the information. Personally, I love AMR. Let me just say this: I'm not so into research, but AMR is something that is in my heart, and also, yeah. So nimeambiwa nikuja hapa na wasaidia ku stretch, si ndio? Honestly, I have no idea what I'm going to do. But So in MKU we are fun people. So we, what to MKU? MKU? Jkuat. Need to Anyway, I think we can just stretch too. Remember when we finish a stretch? Inweni mikono juu stretch. Alafu obviously naweza kuambia turn to your neighbor. Sijai preach, so let me use this opportunity to do this. Turn to your neighbor, mwambie unakaa poa. Naka umekaa ile mbogi pale sipendi. Mbona unamwambia nakaa? Anyway, I hope we'll continue learning, and personally I'm having a lot of fun. Thank you so much Jkumrek and everyone who's organized this. We've gone and seen the botanical gardens, and I think nitaacha kutumia Jkuat sasa sana juu that garden looks nice. But yes, that's it. I hope tuendelea kulearn. Yes, thank you Eldon.
So, I think you can all sit down. I think he has done a good job, and he's a good friend of mine. Ananikana tu hapa. So we're going to have 3 abstracts. As you have said, this is a realm of researchers. We are the next generation of researchers. So please concentrate, learn, and learn. So the next presentation is an abstract presentation on prevalence, mortality, and risk factors of cancers in Karatina Sub-County Hospital, Nyeri County, Kenya. It's going to researchers. Our presenter will be Johnson Kamau, I believe is around. Yeah, Johnson Kamau, please come forth and present the abstract. Thank you so much.
For organizing this. It's wonderful. So my name is Johnson Kamau. Yeah, I was privileged to do a research and happy. And in our group, we were 6 people. Edith Kandie, Faith Ann Nyagechuhi, Karen Wangari, Asmahan, and Sami. And our supervisors were Dr. Eliphaz Gitonga and Dr. Kenneth Irongo. Sorry, I'm Johnson Kamau, a BSN student for the year at KU. So our research was on prevalence, mortality, and risk factors of cancers in Karatina Sub-County Hospital, Nyeri County, in this great nation of ours. So the background, cancer, as you all know, is a generic term for a group of diseases that affect any part of the body, and it results from interaction between a person's genetic factors and internal and external factors. The global burden of cancer is growing alarmingly, and it accounts for 1 in every 6 deaths in the world, according to WHO. So in Kenya, it is the 3rd leading cause of death after cardiovascular and infectious causes. And the reality of this burden strikes less per locality or small geographical areas in Kenya, such as Karatina Sub-County. So cancer is a leading cause of death worldwide, and it has accounted for nearly 10 million deaths in 2020. And healthcare workers at Karatina Sub-County Hospital have also reported a large number of GIT cancers, especially esophageal cancer. And the report indicates, thank you. The report indicates little knowledge of the potential risk factors, mortality, and the prevalence in the male and female patients. There is little empirical literature on the prevalence of the different types and subtypes of cancers. a broad objective is to determine the prevalence, potential risk factors, and the mortality of the different malignancies in Karatina Sub-County Hospital. And specific objectives were to determine the most common malignancy in the hospital, to determine the predisposing factors to the different malignancies. Our study was a cross-sectional analytical design done at Karatina Sub-County Hospital, Nyeri County. And the study population were patients who have been managed for cancer at the hospital. We included residents of Karatina who had been managed for cancer, and we excluded non-residents of Karatina and those not diagnosed with cancer. So we used a systematic random sampling method to select files that were used for the study. And since also the study involved key informants who are the healthcare providers, we used a purposive sampling technique to identify them and the patients. So sample size, we used Fisher's et al. Formula. We arrived at 150 participants, having taken 11% as the prevalence of malignancies, according to a study done at MTLH by Masharia et al. We collected data from patient files, analyzed data using Microsoft Excel, and the prevalence was calculated. Odds ratio, p-values were used to determine the predisposing factors. Seeked approval, ethical approval from KUERC, Karatina Sub-County Hospital Administration, and the Nyeri County Administration. So, on to the results. Socio-demographic factors, risk factors. So those were the results, and I'll just go to the results. The majority of the respondents were suffering from malignancies were male. They were farmers, they were cigarette users, and they were alcohol users. The findings were in line with the responses obtained from the key informant interviews and the patient interviews. And the majority of the respondents had no family history of malignancy, and over 1/3 of them, that is 36.7%, died in the course of the disease, managing the disease. So the prevalence, esophageal was the highest prevalent, followed by cervical at 10%, gastric 8%, prostate at 7.3%, and the rest. So the mentioned assertion is in line with the findings of the quantitative analysis and also from other researches that were done by in MTRH and KNH. So predisposing factors. So we did a binomial logistic regression to investigate the predisposing factors. So sex at a p-value of 0.013 was significantly associated with esophageal cancer, whereas smoking, alcohol, and family history were not. And being a female gave the respondents a 2.6 less chance at an odd ratio of 2.565 and a p-value of 0.13 of having esophageal malignancy. So an increase in age by 1 unit gave the female respondents a 3.3% higher chance of developing cervical cancer. So, and an increase in age by 1 year of the male respondents gave them a 5.7% higher chance of developing prostate cancer at an odd ratio of 1.057. So the respondents who smoked and used alcohol were 5 and 11 times more likely to develop laryngeal cancer than those who are non-smokers and non-alcohol users. So those who had a family history of cancer were 8 times more likely to develop breast cancer, and in comparison with those whose family did not have a history of cancer. So just to say, sex, age, smoking, alcohol consumption, and family history were the risk factors that we obtained from the interviews. So we did a case fatality rate, and we found that in every 100 people, of those people suffering from cancer, that 7 die from it, which is a high number, right? So prostate had the highest mortality rate, followed by esophageal, then gastric, then cervical cancer, laryngeal, and breast cancer. Yeah. So as we compare the male and female respondents, esophageal were found more in male. Yeah. So sex was a significant predictor of esophageal cancer, laryngeal, and breast malignancies. And laryngeal cancer we found only in the male respondents. Gastric and esophageal cancers were more prevalent in males than in females. Breast cancer was only observed in females. So as I conclude, the number of patients suffering from cancer has been increasing over the years in Karatina sub-county, and our study found that most of the participants suffering from different malignancies were males. They were farmers, they were cigarette smokers, and they took alcohol. So those were the most common malignancies, and the prostate cancer had the highest mortality. So our study had several limitations, one being poor record keeping and incomplete filling of patients' documents by the health providers, and some patients go home with some of their diagnostic documents, resulting to inconclusive data, and a lack of proper follow-up scheme for the patients resulted in inaccuracy in determining the mortality. So we recommend that there be proper documentation, there be community sensitization, expansion of the lab at the hospital, and the high prevalence also warrants that there be an oncologist, because there's no oncologist there, to enable provision of more comprehensive care, and there be proper reporting of cancer cases in a regional and national registry for better capturing of demographics. So we also recommend for further research, especially maybe a prospective cohort study to identify the risk factors. So thank you, and we acknowledge HAPI, our supervisors, and Kenyatta University. Thank you.
Thank you so much, Johnson and the team in absentia. Cancer, all of you can vouch for this. Cancer is among the rising cases of non-communicable diseases, not only globally, but also nationally. And researchers of this sort are key and very important in ensuring that we curb the rising epidemic on non-communicable diseases. As he has said, they are preventable, because the etiology, another thing, first year's etiology means the cause of a disease. It's okay. So the etiology is preventable. So if we are ambassadors of ensuring that we prevent and we ensure that there's some lifestyle modification, we can curb this rising burden of non-communicable diseases. Thank you so much, my brother. The next presentation, today we're doing groundbreaking presentation, guys. So brace yourself. So the next presentation is a presentation on assessing provisions of psychological support among women receiving post-abortion care in reproductive health unit at Thika Level 5 Hospital. Another important topic. I think our presenter will be Lamek Otieno. You're around? Okay, thank you. And I think Lamek also has a chaperone. They're all in tie. Looking sharp.
Good morning. So my name is Lamek Otieno. I'm a fourth-year nursing student from Kenyatta University. Just to bring to your attention that this study was multidisciplinary, granted by HAPI. These are some of my co-researchers and the research mentors. With me, I have a co-presenter, that is Frederick Nondu. He's seated here. He'll join me later. Yeah. So that was our research topic, assessing provision of psychological support among women receiving post-abortion care at the reproductive unit in Thika Level 5 Hospital. So on the background of this study, so abortion is the termination of pregnancy prior to 20 weeks of gestation. That is according to WHO 2022. And about 73 million abortions are secured yearly. So when you come to Kenya, you notice that by 2012, we had around 464,000 cases of induced abortion. And so why is psychological support a problem? So you notice that abortion causes health complications such as stigma, physical trauma, and emotional and psychological problems. This is stress and what have you. Women who have secured abortion sometimes are, not sometimes, but most of the times they are labeled and given names like prostitutes. Most of them are called murderers, and you know that. And this causes feelings of guilt and suicidal ideations in the minds of these people. So you also notice that post-abortion care package should be given to all women, whether the abortion was self-induced or it was spontaneous. Now, we had 4 objectives in this. One was the component of PAC. Another one was to determine the level of provision of psychological support given to post-abortion women. The next one was to determine personnel offering psychological support services. And lastly, to find out the perception of women regarding psychological support services. We had only, this was a descriptive cross-sectional study design, and we only had a main variable, which is from the study topic. The study was done at Thika Gyne Ward, and the study population was women who are receiving post-abortion care in such unit. So our exclusion criteria, women who did not consent did not take part in this study. And we had a sample size of 53 that was conveniently distributed among files, healthcare providers.
It is, according to KNPR, the load were noted to be chronic defaulters to the clinic, and so it was quite a big problem to manage the condition. Poor patient outcomes such as mortality and morbidity, which I will expound on later. Also, in the justification of our study, that as I had stated earlier,
the hospital and treatment happens outside the hospital.
Thank you. Let me give a chance to somebody in the back bench. Nimona some 2-3 people wakidozo of, let me see, I think from the back bench. What have you learned? My brother, Gitonga.
So I've learned about the post-abortal care, where you find most of, despite receiving that, let's say they have come in with an incomplete abortion and they need that manual vacuum aspiration. We as doctors and as also other healthcare stakeholders, we just act basing on the pharmacol. Let's say
your hands, pick a plate, serve. Asanteni sana.
It is, according to KNPR, the prevalence rate of HIV at Nyeri County was at 5.1% compared to the national prevalence of 4.9%. So this was a this was quite a big problem, and so we sought to establish the factors that determine the patient's adherence to the antiretroviral therapy, their clinic attendance, and the rate of defaulting or their loss to follow-up. Also, a notable proportion of the patients attending the clinic there who had a high viral load were noted to be chronic defaulters to the clinic, and so it was quite a big problem to manage.